Thanks, Paul, for that introduction and for recognizing the role of allotransplant as the original immunotherapy. So I'd also like to congratulate both Andy and Craig on the honor and also the honor for me to be part of this symposium today. So I thought I'd talk a bit about allotransplant and lymphoma and touch not just on non-Hodgkin's lymphoma, but also have some slides on Hodgkin's lymphoma towards the end. And as you can see from CIBMTR registry data, lymphoma is actually one of the most common indications for transplant in the US, and in green is autologous transplant, and in blue is allogeneic transplant. So it's the second most common indication for transplant overall, second most common for auto transplant, and certainly one of the common indications for allogeneic transplant. As we can see over time in the US, the number of transplants has continued to rise, and this is even in the presence of new therapies, including immunotherapies. And when we think about the two transplant modalities, obviously there's significant difference between autologous and allogeneic stem cell transplants. And one of the main differences is obviously the risk of relapse. So if we look at causes of death after transplant, almost almost three-quarters of the patients who die following an autologous transplant will die of relapse. Whereas after an allogeneic transplant, and this is data from related donors, but using related donors is quite similar, only about 40% of patients will die of relapse, and they will die of other complications. And so immediately you see this difference in the risk of relapse. And this is due to the so-called graft versus leukemia or graft versus lymphoma effect. And I think this is nicely illustrated in this paper that was published a year ago by the CIBMTR, which is sort of a rehash of the original Mary Horowitz paper looking at the incidence of GVHD and relapse, and looking at patients who have no GVHD, acute, chronic, and both acute and chronic. And you can see here for two subtypes of lymphoma, mantle cell and follicular lymphoma, there is a relationship between the incidence of GVHD and the severity of GVHD and the risk of relapse. And the more GVHD you have, the less the risk of relapse. Now, of course, these patients do have other complications and morbidity associated with that. But I think this, again, illustrates this notion of a GVL-GVHD effect. And so what are some of the unmet needs of allogeneic transplant in 2016? And one of them certainly is access to transplant and availability of donors. And then, obviously, some of the complications. We've talked about relapse, but GVHD and infection remain challenges as well. Now, in terms of the numbers that we see and the donor situation, the most common transplants today remain using related donors or volunteer donors. But we can see that there's an increase of cord blood transplant as well as so-called allorelatives. And so if we focus on the bottom part of the slide, what we see here is that the use of cord blood has sort of remained relatively stable to slightly decreased in the US, and there's been a significant increase in the use of haploidentical transplants. And this is primarily due to the work that was developed at Johns Hopkins and very early on done in collaboration with investigators at the Hutch, including David, who's here, looking at the use of post-transplant cyclophosphamide in the patients receiving haploidentical grafts. And this has really taken off, not just in the US, but there's very similar data in Europe. And once you get out of Europe and the US, the so-called more developed countries, if you go to India or China, Haplo is sort of really skyrocketing. And I just came back from the meeting in Beijing, and they did 670 transplants, allogeneic transplants at Beijing last year, and more than three-quarters of those were haploidentical transplants. And I think this is really the way of the future, certainly for those countries. And so that's this haplo transplant work. This is, again, registry data comparing progression-free survival and overall survival in patients with non-Hodgkin's lymphoma undergoing a transplant, either with a MUD or a haploidentical donor. And you can see the survival is quite similar. And we have similar data for leukemia. And so I think, though the follow-up is relatively short and this is a relatively new modality, certainly in patients who don't have a match-related donor, either family member or unrelated donor, a haploidentical transplant is certainly a consideration. And while we do a lot of cord blood at our center, I think either modality is appropriate to consider, and it really depends on the center preference. Now, one of the issues that comes through time and time again when we look at it in allotransplant is the issue of timing. And we know that whichever graft source we use, the earlier we transplant the patient in the course of disease, the better they do. And so if you take patients with early stage disease, intermediate stage disease or advanced disease stages, the patients who are transplanted early do better. And as a result of this, the NMDP and the ASBMT have a yearly document that they put out which recommends when patients should be referred for transplant. And so they have, this document that is developed every year, and these are the indications for non-Hodgkin's lymphoma. And so I'm going to go through this disease by disease. And so for follicular lymphoma, the current recommendations are patients who respond poorly to initial treatment, have a short remission duration at first relapse, or who have transformed disease. And these are indications both for auto and allo transplants. I'm not necessarily just focusing on allo transplant here. And this is looking at the allogeneic transplant data for follicular lymphoma from the registry. And you can see that patients with chemosensitive disease at time of transplant in blue and in orange, those patients actually do quite well with allogeneic transplant. And these are patients who typically have failed multiple lines of therapy, including in some cases autologous transplant. And so we still have the ability to provide a significant survival in these patients. Obviously, in the patients who are resistant at the time of transplant, we drop significantly. I'm around 40% with the amylated donors. And this is data from Matt Lunning, who's a former trainee here and is now at Nebraska and is actually in the audience today. And he looked at the difference between patients who had follicular lymphoma and had either an autologous or an allogeneic transplant at our center, and showed that in patients with a short remission duration, meaning less than 12 months, there appeared to be a benefit, at least in terms of event-free survival for allogeneic transplant over autologous. Although in the overall survival, the advantages that we had in terms of graft versus leukemia effect or lymphoma effect were balanced by increased non-relapse mortality associated with GVHD primarily. Switching now to DLBCL, the recommendations currently from the NMDP and ASBMT for consultation are primary induction failure, patients with high risk or high intermediate IPI, at first relapse, CR2 or subsequent remission, and double-hit lymphoma. And the ASBMT has actually developed guidelines for transplant in NHL, and these guidelines now are a little bit outdated. They're about 5 years old, and actually Matt is developing updated guidelines for the ASBMT that will be coming out presumably next year, and that will review all the current data for transplant in both autologous and allogeneic in NHL. And this is looking at some of the registry data, and again, you can see for autologous transplants, we do quite well with patients who have sensitive disease at time of transplant. The results are not as good with patients with resistant disease. And if you look at the data for allogeneic transplant, the curves are not that dissimilar. And so the experience really is that the outcomes in terms of response to therapy with both autologous and allogeneic transplant are similar. There is some increased non-relapse mortality, which offsets the benefits of the allogeneic effect. And an important paper, I think, that was looked at recently, which is, again, registry data, is looking at the outcomes of patients with large cell lymphoma who failed an autologous transplant and then proceed to allogeneic transplant. And you can see that there's about a 40% survival rate in those patients. So I think even in these patients that we often think of as beyond salvage, we still can salvage them successfully with an allogeneic transplant. And Gunjan Shah, who's one of our junior faculty on the transplant service, has very similar data from our center looking at this patient population. So our results are consistent with what is seen in the registry. And in Tim Fenske's paper, we were also able to develop a prognostic indicator for outcome in these patients. And you can see at least that some of the patients, looking at their performance status, the remission duration, and the fact whether or not they had resistant or sensitive disease at transplant, that some of them have pretty good results in the order of almost 50% long-term survival, whereas the patients who have a poor prognosis do very poorly and obviously should probably be referred for investigational therapy rather than an allo transplant. And this is hot off the press, so I thought I'd include it today. This is online now in JCO, I think, as of yesterday. And this is looking at the outcomes of autologous transplants in patients with double-hit lymphoma. This is a cooperative study between the Dana-Farber and the City of Hope. And you can see that for autologous transplant, looking at overall survival on the left and PFS on the right, that patients with double-hit lymphoma don't do as well as we'd expect or as we'd like with autologous transplant. And the question is really whether these patients should undergo transplant or should be referred for other therapy. And in one of the other figures from this paper, they also look at double expressors, and the combination of double hit and double expression, those patients do terribly and really should not be referred for transplant. So I think, obviously this is a moving target, and we need to think about additional modalities for these patients. Now, in mantle cell therapy, the practice has been to refer patients pretty early in their course for at least consideration of transplant. And when we look at the results of autologous and allogeneic transplant in those patients, we do see that there's a survival. The autologous transplant data, the curve sort of tends to go down over time, and eventually it probably meets the allogeneic transplant survival curve, which tends to flatten out. And this is data from our own center looking at allotransplant for patients undergoing allogeneic transplant for mantle cell. And you can see that we have a reasonable overall survival rate in the order of 40% long term, and that the SIPI is actually predictive of survival. And the patients with a low SIPI do particularly well versus those with a higher IPI. So switching now to Hodgkin's lymphoma, and particularly since Craig is in the room, I'd like to acknowledge Craig's mentorship over my years at Memorial, and he's really somebody who's mentored me significantly as I've done work in Hodgkin's lymphoma. So we published last year updated guidelines for transplant in Hodgkin's lymphoma, and this was a large cooperative effort with multiple centers. These are the guidelines for autologous transplant, and these are the guidelines for allogeneic transplant. And these are evidence-based reviews that we did. And so I think, in 2016, the recommendations remained that allogeneic transplant should be considered for salvage therapy after relapse after autologous transplant. And that's probably the only curative therapy. And we may have a lot of new therapies that you've heard about today, but I think at the end of the day, this is still the one therapy that we know has a cure rate. And the standard approach is a reduced intensity transplant. And the issue of whether patients have a donor or not, I think in 2016, virtually everybody has a donor. Between cord blood and haploidentical transplants, and a study that we're about to start with this IBMTR that will look at the use of mismatched unrelated donor transplants using post-transplant cyclophosphamide, everybody will have a donor. And so I think this is still something that should be offered to these patients. And these are results of an intent to treat study I did, and that presented recently, looking at the role of allotransplant in Hodgkin's lymphoma. And the way this study was designed was very much based on the work that Craig had done previously with autotransplant. And the idea was, let's take patients who relapse after an autotransplant, enroll them on study, provide salvage, look for a donor, and then proceed with an allotransplant. And these are difficult studies to do because it involves collaboration between different services and getting the patients sort of enrolled on study at the right time. But what we see in this small cohort of patients is that of the 15 patients who were enrolled on the intent to treat, 5 of them, so 1/3, actually failed the study because they progressed. And then we looked at the other patients, and anybody who basically had at least a standard, at least stable disease could proceed to allotransplant. And then some additional patients were transplanted on protocol without going through the intent to treat. And so when we look at the analysis based on the intent to treat, obviously you see a significant difference in patients who respond to salvage therapy compared to those who don't, who basically are all dead of their disease. And then if you look at the whole cohort, including the non-intent to treat patients, you can see that the survival after allogeneic transplant for Hodgkin's lymphoma is around 40%. And this is very consistent with what we see in the registry. And then in a larger analysis of results from our center, we also looked at functional imaging, again, similar to work that has been done on the lymphoma service looking at autotransplant. And you can see that, as you would expect, functional imaging is predictive of survival after allogeneic transplant in patients with Hodgkin's lymphoma. And this is registry data looking at results in allotransplant. But obviously, the big question in 2016 is what do we do with all these new drugs, and particularly the checkpoint inhibitors? And so this is taken from a recent review by Anas, looking at the efficacy and response rates of PD-1 drugs in different diseases. And you can see here on the left that lymphoma really stands out as some of the most active diseases in terms of response rates. And these drugs have now been used after transplant. There have been 2 publications now with ipilimumab for relapse after allogeneic transplant. And the concern was always, well, what are we going to do with these drugs in the transplant setting, in the allogeneic transplant setting in terms of GVHD? Because presumably if you take the brakes off the immune system, the risks of GVHD are going to be significant. So in the first study, and this was a one-time dose of ipilimumab for relapse, 29 patients were treated, no GVHD was observed, and they had 2 CRs and 1 PR. So this was sort of intriguing, showed that it could be done safely, but obviously the response rates were not that great. And so the group at the FARB, in collaboration with others, led a multi-center study where they gave repeated dosing of ipilimumab and looked at 3 micrograms per kilogram and then 10, and treated a number of patients. And you can see that in the 22 patients who were treated at the higher dose, they actually had 5 CRs and 2 PRs. They did see some GVHD and they did see some immune adverse events. But this is an example of a patient with leukemia cutis, and you can see that the disease goes away after ipilimumab. And so I think this study demonstrates that we can safely give these types of drugs after transplant for patients who relapse and maybe enhance the GVL effects in this setting. And the other thing that was interesting in the study that was published in the New England Journal is that they were able to identify an immune signature for the responders. And so I think this sort of gets to some of the biology and the balance between regulatory T cells and effector T cells and how that may play a role in the use of these drugs post-transplant. And there's also at least 1 case report that I'm aware of looking at PD-1 blockade after relapse after transplant, and this patient in this case report did well. But I think the question that is maybe more relevant to us today in terms of practice is in these patients who are now getting drugs like PD-1 checkpoint inhibitors, can we safely take them to an allogeneic transplant? Because these are patients that we're seeing in more and more in the practice. And so Philippe Armand and one of the junior fellows at the FARB put together a series of 39 patients, and this is a collaborative effort. We actually submitted several cases to this manuscript. And the question was, could we safely do an allotransplant after PD-1 drugs? And so of the 39 patients, you can see this is the non-relapse mortality, and this is the relapse rate. What's interesting is that, and about, I think 17 of these patients were actually Hodgkin's patients, that the relapse rate, given the high risk of these patients, was actually lower than predicted. And the non-relapse mortality was actually reasonable, and certainly we didn't see very high non-relapse mortality that we were concerned about related to the prior use of PD-1 drugs. And these are the overall and progression-free survival curves for this cohort. And so what's interesting is the rate of acute GVHD in this study was actually what you would expect using these types of patients. But there was an additional cohort of patients who had immune adverse events such as pneumonitis, hepatitis that actually required steroids. So if you look at the burden of steroid use post-transplant, either for GVHD or for these immune adverse events, it's actually more than you would normally see after an allogeneic transplant. So definitely immunological effects that can be seen. And I think one of the take-home messages is that it can be done, but these patients have to be monitored closely and interventions have to happen quickly. And one observation they had is that these patients have an early febrile syndrome which responds to steroids, and they have some cytokine data to sort of explain this. And this seems to be particularly present in patients who get prior PD-1. And actually one of these patients was somebody we treated at our center. This was a patient with Hodgkin's lymphoma who had probably 10 lines of therapy prior to coming to transplant, including IPI and Nivo, and was actually in a partial remission at the time of transplant, got a haplo-identical transplant, and very rapidly after the graft went in and before the cyclophosphamide was given, developed high spiking fevers, became hypoxic, creatinine doubled overnight, and we checked the CRP, and the CRP was, as you can see, quite high. And so we gave him tocilizumab because as our center, that's what you do when the CRP is high. You give tocilizumab because you have it at the bedside. Interestingly, we did check the IL-6 because I didn't want to see what the IL-6 would be. And the patient actually responded to tocilizumab, then went on to get the cyclophosphamide and has since done well. And when we looked at the IL-6 levels, the IL-6 levels were also through the roof and then came down after tocilizumab. There's been since then a publication from the WashU group that has also had the same observation, and they're actually using tocilizumab prophylactically in their haploidentical transplants in what they consider high-risk patients. And that may be sort of going a bit far, but it's certainly something worth discussing. So to summarize, I think that allogeneic transplant remains relevant in 2016 for patients with lymphoma. And here I'm again showing you the slide from Alvaro Urbano's paper last year looking at this balance between GVHD and GVL. And what I like about this paper, in addition to showing the specific effects of GVHD in different histologies, it also gives us a large data set for lymphoma where you can look at survival rates in the different histologies within the registry. And so this is sort of the real-world survival rates for non-Hodgkin's lymphoma patients and Hodgkin's lymphoma undergoing allogeneic transplant. And so with that, I'll close and take questions.